this is an MRI images showing soft tissue edema at the right femur and greater trochanteric with muscle edema, soft tissue edema, and involvement of the cortex, which appear ISO on T1 and hyper on T2. And on post-contrast, there is enhancing well-defined collection seen, two collections. And can I have a clinical history of the patient, please?
Right leg pain.
Does he have fever or anything?
Yeah, he's got a fever.
PSR elevated.
CRPs 70, white cell counts 25.
Yeah, findings are suggestive of infectious process like osteomyelitis. And this is most likely an aggressive appearance as infectious like osteomyelitis and abscess.
Okay, so quick question. If I didn't tell you the inflammatory markers, without the inflammatory markers, what would you have thought it was?
Of aggressive lesion, since there is an edema and the cortex be breached, and there is like enhancing collection. So I'll go with osteomyelitis or Ewing sarcoma, aggressive lesion rather than just simple benign lesion.
Okay, thank you. So, and this is osteomyelitis. So you've got soft tissue edema. You've got this periosteal elevation. And yes, so this is a T2 fat suppressed, and you can see marrow edema as well here between the greater trochanter and the epiphysis, the metaphysis. And this is apophysis, which is similar to epiphysis, just that it doesn't add to the lengthening of the bones. Okay, so this is apophysis, and this would be the metaphysis, as you normally know in your long bones. Soft tissue edema, that's your that shows you again on a coronal. Now, things to be aware of is in a kid, in osteomyelitis in adults, your T1 is your friend, because focal areas of low T1 signal suggests of a marrow process, which can be infection or malignancy, and it should be lower. So iso or hypo-intense to muscle, which suggests it's a marrow abnormality on T1. But in kids, we've got red marrow, which makes things a bit difficult. So T2 is your friend. And of course, in kids more than adults, infection is one of the top differentials, osteomyelitis, which is why we often give contrast. Now, some people say can do T1 pre-contrast and then post-contrast, but I find that sometimes with the fat, it makes it hard to see. So my preference is a T1 fat set pre-contrast and then T1 fat set post-contrast. But I think that's down to personal preference. So there shouldn't be, looking at these pictures in my head, there shouldn't be a differential of Ewing sarcoma, because the post-contrast things are the giveaway. That looks like an abscess with surrounding enhancement. And a reason why is because this is a cortical breakthrough from the periosteal abscess. Now, osteomyelitis can happen. So we'll just go to the next slide first. So there are different bugs depending on their age. So 6 months to 4 years, you think of Kingella. If you've got sickle cell, you think of Salmonella. Staph aureus is the most common. And of course, if you have any penetrating injury, I think you have Pseudomonas. Often you get it in the metaphyses, like what Dr. Kapoor mentioned earlier. Of course, often the long bone metaphyses. Now, bone loss or osteopenia is only seen if you lose 30 to 50% of bone. And so if you have a normal x-ray, as per adult osteomyelitis, it doesn't mean that you don't have it. And so you want to use MR to further characterize what it is. And, like what we said here, periosteal reaction, periosteal abscess, really, soft tissue edema, you can have a joint effusion if it goes into the joint, okay, or even just a reactive appearance, a reactive phenomena. The only thing here is that bear in mind why it happens in the metaphyses is because you've got the vascular supply, it's very vascular there. And also you can get it in the subperiosteum or subperiosteal region, again, because the periosteum is very vascular. The only caveat is that if you are in a young infant, so if you're in a baby, and also in old adults, where you don't have that barrier, that faeces barrier, because in infants, you've got transfacial vessels, okay, so it goes across the faeces. So in kids, in infants rather, because those vessels stop after infancy, after a year. So if you have them at a younger age, so infancy, i.e. osteomyelitis, you want to rule out septic arthritis because it can extend from metaphyses through the transfacial vessels to the epiphysis and then subsequently into the joint space, i.e. septic arthritis. Same process goes into in adults. You don't have that facial barrier, which is a vascular barrier. It just goes straight through, so osteomyelitis plus minus septic arthritis in adults and in infants. But above the age of 1, you get the nice avascular barrier of the faeces, which acts as a protective layer. So your metaphyseal infection, which is often a hematogenous spread, does not go into your epiphysis and subsequently into your joint. However, it can spread transcortically into your subperiosteal space, hence giving you the signs of subperiosteal abscess. Some people say, do you start in the periosteum first or do you start in the metaphyses first? Nobody really knows. It's a chicken and egg situation. So some people only have just purely metaphyseal disease. Some have purely subperiosteal disease, and some have a combination of both. Okay, so that's osteomyelitis. So another example, so this is in a younger child. We can use ultrasound to help us delineate it as well prior to MR, but I personally prefer MR. So, but you know, it can correlate with both even better. So on ultrasound, that's your oscillation center of your distal femur. That's your femur, that's your bone, because bone is nice and bright. You've got soft tissue changes on top. You can see it's quite florid and should be nice and smooth, not looking very edematous. And then looking at the soft tissues, the bones here look quite craggy. Okay, so that's the axial or TS view. You've got a little fluid collection here, could represent a soft tissue collection, and there's some erosions going on here. So erosions, you need 2 planes. Unfortunately, I don't have 2 planes here. I've got 1 plane in the TS, and you should have another one in LS to confirm that it's erosion. But then we look at it on the X-ray that was done. And in PEDS, we often like to have different modalities to correlate what we are seeing. We get better that way. And you can see that that's very ill-defined distal femoral metaphyses showing these bony erosions of infection. Okay. We've got another one. So septic arthritis of the SI joints, very common in kids. Don't ask me why. And what you're looking for is the characteristic sign. So this is T1. So you can see how that there's a lot of red marrow. So T1 is not really your friend in helping you tell whether there's marrow infiltration. But SED stir is quite good. So that's your SI joint here. It's nice and so it's there, nice and straight. And what you have here is just quite a lot of fluid, a high signal within the joint, extends outwards into the soft tissues. And then post-contrast, you see these nice little abscesses within the soft tissues. And this is capsular hypertrophy or protrusion. And that's one of the key features to know if there's a SI joint effusion, this capsular bump at the top part of the SI joint. Okay. Next case. Candidate 3.
Yeah, this is a right shoulder X-ray for a skeletally immature patient. Okay. I'm looking at the bone to check if there is any bone abnormalities. I can see a widening at the space of the right acromioclavicular joint. And the right humerus look good, the epiphysis. The ribs, the trunk.
Do you want to ask me?
You can only see the right acromioclavicular joint is like there is widening.
Okay, so what if I tell you that you can feel a palpable lump or pain at the medial clavicle on the right?
At the medial clavicle at the right? Okay, I might see like an expansion seen at the medial aspect of the clavicle, and however, no cortical disruption or periosteal reaction. Does the patient have anything else like rheumatoid arthritis or known case of anything?
Nope. She tells you she's got right-sided pain, or she presented right-sided pain. Now she also has left-sided pain. So I've got more pictures.
Yes, please. Okay. All right. This is an MRI showing a bone marrow edema at both medial aspect of the clavicle with soft tissue edema surrounding it. And at the right ankle, there is also a bone marrow edema at the physis with lucency, lytic hypointense lesion seen at the physis with surrounding edema. So it might be due to multifocal osteomyelitis, since the patient have a multifocal site with bone marrow edema, soft tissue edema, and at the physis, which could be due to infectious process.
Yeah, well done. So going back to the first one, so you can see that there's actually expansion of the medial clavicle. You're right. There is no significant bony destruction, but what you have here is periosteal reaction along the medial edge, just underneath here, and possibly along the top. This is smooth periosteal reaction, suggesting this is a fairly chronic process. Because if you, like what Dr. Kapoor said earlier, when you have more aggressive periosteal reaction, the bone has not had time to lay down, so you get partial laying down bones, and then with destruction, so you get Codman's triangle. Can you imagine that the periosteum is trying to lay down, but part of it is just not, because it's being eaten away by whatever destructive process is. So there's smooth periosteal reaction, bone expansion. Now in kids, why is it that you see this? That's because if you think about it, go look back in your textbooks, your acromion ossification center is still cartilaginous, so you don't see that. But in any case, if sometimes you're thinking, oh, is there AC joint dislocation? I think that happens very infrequently in children, and what happens is that you actually get a Vulgent fracture of the distal clavicle, and then subsequent to that you can get a very large periosteal hematoma, making it look a bit like malignancy, okay? But then MRI will help you clarify it, but just remember your acromion ossification, actually, I don't think it starts to form until you're about your 20s, or early 20s, or late teens. It's why you never see the acromion. Right, so there's MRs here now proving that on the right side you've got abnormal marrow edema. You can't appreciate the periosteal reaction as well, but maybe there's this elevation here and the bottom is bit well, and also on the left side, so bilateral clavicular involvement in your tibia, and fibula, and there's the fibula because you've got your perineal tendons running along here. It's metaphyseal region without the clavicles. You think, is this infection? But putting 2 and 2 together, you rightly got it as a CRMO. You've got another case here, so same case of CRMO, but different patient, now showing you a more florid reaction in the bone marrow. But again, you can see that it's expansile, it's thickening, cortical thickening, and initially in isolation, we made a mistake of, I called it off, this is malignant because this looks aggressive. However, what happened was that we then did a CT scan, which showed that actually there's actually quite nice smooth periosteal reaction, suggesting that it's more of a chronic process, and because of the clavicular involvement, we are thinking more CRMO. Nowadays, with whole body MR, people use it to see if there are any other sites of asymptomatic disease, and often you're thinking things in the knees and ankles. It's one of those sites, and then you're looking for metaphysis involvement, but often they can cross the physis and be epiphysis as well, as in this case. So this was discussed, the bone tumor unit is what we normally, because initial thought, and given the MR findings, this was more likely to be CRMO. So just a little bit of what it is. So it has a relapsing remitting course. Of course, it's not non-pyogenic. Well, they say non-pyogenic because it's not. There's no bacterial growth. Typically multifocal, but patients can still have systemic features of like fever. So it's like a systemic GIA picture. It is more common if you are at higher risk if you do have some underlying inflammatory disease. So good for your question of is there any underlying GIA. You get multiple sites involved, and I said earlier, long bone metaphyses or metaphyseal equivalents, and it's the most common disease to involve your medial clavicle. In the adults, you think of cepho, which comes with pustulosis and skin changes as well. And of course, like anything, when it's acute, it can be lytic, and then later as it starts to heal, you get that adjacent sclerosis, and of course, if it comes back again, you can have new lytic areas. So it's a waxing, waning course of disease, and use a whole body MR to screen. And if you've got multifocal disease, then it's more likely to be CRMO. But of course, you need to think about things like metastases, because if you've got a primary cancer, then of course, can be, you correlate with clinical history, any weight loss, any systemic symptoms, how the blood markers. Sometimes you even do an abdominal ultrasound just to screen your normal things like Wilms tumor, neuroblastoma, and so on. A blood film to just make sure there's no evidence of leukemia. Okay. Right. Another case.
Okay, this is an MRI, T1 and T2 fat SAD for the left hip, showing surrounding joint effusion at the left side. This effusion surrounding the left femur. However, there is no definite bone marrow edema. At the acetabulum, there is mild breaching of the cortex seen. However, no bony lesion is seen. I'll think of septic arthritis, since there is a large joint effusion with no significant underlying cause of a bone lesion or anything to cause it.
Okay. So you've got more information. You go back to previous history and you see other findings within the patient's packet that the clinicians haven't told you about. What do you think?
There's a wrist X-ray for skeletally immature patient showing like generalized osteopenia at the X-ray with multiple subchondral cysts. However, no definite bone fracture or bone lesion could be seen. There is some kind of ankylosis, I'm not sure about it, at the carpal bones. At the MRI, there is a joint effusion with multiple bone marrow edema at the carpal bones and at the styloid process of the ulna. There is erosion also and like soft tissue with multiple subchondral cysts. And on ultrasound, there is fluid with echogenic material, not clear fluid, with like debris. So I'm thinking of a systemic disease, maybe rheumatoid arthritis, since it's affecting the carpal bones.
Okay, and in good. And if you're thinking of an inflammatory arthritis in kids, is it called rheumatoid?
Juvenile rheumatoid arthritis, it's occurring more with ankylosis. It's the juvenile rheumatoid arthritis.
Yep. Okay, good. So well done. So MRI of the hip, T1 and T2 stir, and nicely picked up. There's a large joint effusion on the left, not on the right, as in there's always going to be a little bit of joint fluid that's within normal limits. What's interesting is that these presence of this synovial proliferation, almost looking like, very quite rice bodies like, It's just the appearance of it. Of course, we often think of it in something chronic, so like chronic TB, TB, RA. The interesting thing here is there's not much in the way of meridema. And if this was, of course, correlative clinical history, although sometimes it can be hard because, as I said, systemic JIA can have fever and raise ESR, CRP and stuff. But septic arthritis is going to be really painful, often acute flare of JIA or juvenile idiopathic juvenile inflammatory arthritis. People can still go on. They can still carry on. They are not in excruciating pain. So it can be grumbling for quite a while, and then it's incidentally picked up. So it's this synovial proliferation that's quite marked, and the absence of meridema. Often in septic arthritis, there will be some extent of meridema, and of course, prolonging it without treatment, you start to get more in the way of bony destruction, because of the inflammatory process. Now, in small thing, so we do MRI of the hip. We also look for other features. In this T2, there's probably irregularity of the chondral surface. It's probably just an incidental osteochondral lesion that's not associated with the underlying process. On the other X-rays, so what you can see here nicely picked up is that you've got, I guess it takes time to get your iron, but if you look at quite a few wrist X-rays of the same age, you notice that there will be a bit more joint space between the proximal carpal row. Distal carpal row still looks okay. This is the mid carpal row. The space is quite narrowed. It's called a bit of carpal crowding. There's also sclerosis. It just doesn't look very happy in the proximal carpal row. On the left and on the right, you can see it's actually, there is a widening of the scapholunate. You've got decrease, you've got the subluxation of the capitate, all looking a lot like what you think in rheumatoid arthritis if it was in an adult. Similarly, the changes on MR shows the bilateral joint effusion. All these little cystic-like appearances could be subchondral cysts. Could be represent erosions more than subchondral cysts. Probably like erosion given the extent of disease. Now, on ultrasound, this is your classic view of your wrist joint, the radial carpal joint in the midline of your wrist, and the black bit shows synovial thickening. The only bit that I didn't give you was the Doppler, which would show a vascularity, suggesting it's active synovitis. So in rheumatoid, or rather in arthritis in a child, you can get, if you just had treatment, you can have a lack of the Doppler vascularity, but you still have synovial thickening persisting for a bit until the treatment starts to kick in. But you can just notice that on the right side, it is a lot worse than the left, which corresponds with what the patient's symptoms are. Okay. So JIA, juvenile idiopathic arthritis. Apologies if I always use JIA, so I don't really think about what the full name is. So there are different subtypes. They are, of course, beginning before 16 years old. We are not going to the different subtypes here, but you just got to realize that they can be monoarticular, polyarticular, it can be oligolar articular, enthesitis related, so something looking like ankylosing spondylitis, so different types, but technically all you're looking for is inflammation, joint inflammation. Carpus, your carpal bones, the most site of fusion, the earliest sign is carpal crowding. You don't really get the fingers, you don't really get erosions in the fingers, I'm not sure why, but often affects large joints, your wrists, your knees, your hips, your ankles. Okay. And of course, with hyperemia, you can get very long gracile bones because of the hyperemia, balloon or enlargement of the epiphysis and your intercondylar notches. And if you think of enlarged intercondylar notches, the thing you think of is hemophilic arthropathy. Again, same process. You keep bleeding to the joint. You get constant inflammation causing hyperemia, hyperemia causing your bone changes. Same thing. Okay, but easy to think is that whether it's their family history of hemophilia, a simple test to just make sure that the screen. So just some things to show you the difference. So patient, both legs, one has more affected with arthritis on the left and not on the right. You can see the epiphysis is a lot bigger on the distal femur and the epiphysis as well. And then this is one that has a bilateral JIA involvement of both knees. And you can see that widening of the intercondylar notch. To be fair, I think it's hard to, if you are just looking at symmetry, if you're looking at symmetrical both sides without one to compare, then in the absence of other symptoms and purely isolated widened intercondylar notch, I think it's hard to pick up. Okay, and I often have to go back to compare it with age-matched controls to say, is it truly widened or is it just a projection thing? Patient has these long gracile bones flaring of the metaphyses and epiphysis with osteopenia, erosions and all of this, the joint space narrowing. So remember, in inflammatory pathologies, even in kids, your joint space narrowing is diffuse because if it's coated by synovium, that's inflamed, versus in an older patient where osteoarthritis is quite focal because it's due in the weight-bearing aspects. Okay, so inflammatory diseases affecting the joints often give you diffuse joint space narrowing and not focal. Okay. Right, now the other thing that's quite common in kids, we see Baker cysts, or rather fluid within the semimembranosus medial gastrocnemius tendons, the bursa. It's a space, and we often see a Baker cyst. A Baker cyst is idiopathic, but you can also think, is there something driving fluid production, causing it to leak out into the bursa, because it often communicates with joint. You do see it in ages from 2 to 14. And the different thing here is that we always need to make sure on the MR, if you see a Baker cyst or even an ultrasound, make sure there's no underlying cause like an inflammatory arthritis or something else that's driving it. And 2 different patients, and you can see that on this one, you've got synovial thickening, and synovium is based on MR on T2, is these low signal frond-like bits that coats the joint capsule, the space. The joint space, and that's that's basically a inflammatory process driving this Baker cyst production versus one that has mostly joint fluid within the Baker cyst, but none really in the joint space, and no evidence of synovitis. So I think this is just to let you know that if you do have a Baker cyst, although it's reported, just think or make sure that there's nothing else underlying that's driving it. Okay, next type of case. How are we? So, okay, yeah, continue. Candidate 3.
Yeah, this is a pelvis X-ray for a skeletally immature patient. This pelvic X-ray. Okay. What's the history? What the patient complaining of?
Altered gait.
Okay.
This was a family history. This was a family history. Patient was first born born in a breech presentation.
Yes. Okay. I will check if there is any signs of DDH for hip dislocation. As I can see at the right side, there is mild disruption of the Shenton line, and the femoral head epiphysis is slightly smaller, asymmetrical. I want to see the Herglian line if the femoral head is within 2/3 medially, and if there is soft tissue swelling or elevation. It's a bit tilted, the pelvic X-ray, not well centralized. However, I will raise the suspicion of right-sided DDH.
Yep, well done. Yep. Correct. So all the key salient features I mentioned. So Shenton's line, we'll go through that, but this is the left. So the left is the normal one, the right is the abnormal one. It's nice line drawing from the obturator foramen all the way down. Makes a nice smooth curve. You can argue that this is not quite smooth. You can see one line here and then another line here. So there's disruption of Shenton's line. There is asymmetry of the femoral epiphysis. One side is smaller, one side is bigger. The other thing that to look for is that if you draw lines, which I'll show you on the next slide, you draw a line through this. I believe this is the Perkins line. I always get those confused, but essentially a line through the triradiate cartilage, another 90 degrees down along the lateral aspect of acetabulum. So if you draw one here, okay, and draw one here, this should be in the lower inner quadrant, and this is kind of a bit more laterally